Continuing our discussion on innovations in CLL, we're going to now talk about relapsed refractory CLL and standards of care. We have Dr. Bita Fakhri from Stanford and Dr. Nitin Jain from MD Anderson, both respected figures in this field. So, Bita, let's shift to the relapsed refractory setting. First scenario, true disease progression on a continuous covalent BTK inhibitor. Where do you generally go? Do you test for BTKi resistance mutations?
Yeah, if it's a true progression, I certainly check for acquired BTK inhibitor resistance mutation panel. And now we are learning way more. C481S was a very common one, PLC gamma 2. And now with the newer generation covalent BTK inhibitors, you're learning about new mutations like T474 with acalabrutinib, L528 with zanubrutinib. It's validating to find one of these mutations when someone truly progresses on a covalent BTK inhibitor. But we also know that 40% of patients who progress have one of these mutations. So when you see true progression, I bring them back, twice, a few months apart. And if I'm convinced that they're progressing, and even if I do not find resistance mutation, it's time to switch therapy. So because of the similarity in mechanism of action, if someone has progressed on one covalent BTK inhibitor, all three of them, ibrutinib, acalabrutinib, zanubrutinib, are out. So I would not switch from a covalent. For example, if they're on acalabrutinib, I would not go to zanubrutinib because they all form a covalent bond with, the same site. So it's time to switch class. And now we know that with venetoclax-based therapy, the Murano trial resulted in the FDA approval of rituximab venetoclax. But I think we have learned from different trials, including, CLL 13, which was obinutuzumab venetoclax versus rituximab venetoclax versus, triplet therapy, rituximab, obinutuzumab, ibrutinib venetoclax versus chemoimmunotherapy, that surprisingly, rituximab venetoclax is similar to chemoimmunotherapy as compared to obinutuzumab venetoclax. So extrapolating from that trial and also other trials, I think there is a universal understanding in the field that obinutuzumab is not just a me too in terms of CD20 monoclonal antibodies. It does result in deeper remission. So if I choose to go down the route of BCL2 inhibitor-based therapy, my CD20 monoclonal antibody partner is obinutuzumab, and now it's in NCCN guidelines. So hopefully all the practices will have an easy time getting the approval. And also in 2025, pirtobrutinib, based on the Bruin, I want to say 321, resulted in a median event-free survival and progression-free survival of about 14 months. So it is now approved for patients. The original approval was for the so-called double exposed or double refractory patients who have seen both a covalent BTK inhibitor and a BCL2 inhibitor. But based on the Bruin 321, now we know that it's approved in patients who have been exposed to a covalent BTK inhibitor and they've progressed or are intolerant. So in this case, with true progression, a lot of other factors come into play. So pirtobrutinib is also an FDA-approved option that is available to this patient population. And I want to say, that scenario, we learned from Resonate that the median progression-free survival with single-agent continuous therapy with a covalent BTK inhibitor was 9 years. So that is a patient who has had a good decade of disease control. They've had 1 decade to wrap their head around the fact that they're going to be on treatment potentially for life. So it might be mentally easier for them to switch to basically pirtobrutinib. I'm unapologetically biased toward time-limited therapies. That's where, preferences come into play. And I just discussed the data with patients. So outside the clinical trial, the options for the patient that you just described, true progression on covalent BTK inhibitor, with or without the presence of one of the acquired BTK inhibitor resistance mutations, is either pirtobrutinib or venetoclax-based therapy.
So Nitin, how do you handle patients with progression on a BTK inhibitor?
Yeah, so very similar thoughts. Obviously those are the two options in front of us, right? I mean, pirtobrutinib continuous, or when these days obinutuzumab, right? So those are the two kind of standard of care FDA approved options in that truly second line setting. So I think, going back to the question of the BTK mutation. So, I would say that, as Bita was alluding to, up until recently, or 2-3 years ago, the only resistance mutation we knew about was cysteine 481S. And at that time, there was no pirtobrutinib. So the argument was, if a patient is failing ibrutinib, yes, you can check a resistance mutation, but they're failing in front of you. The white count is rising. They're failing. And we know the resistance mutations are not uniform, like universal. They're only present, depending on the study, from as low as 30-40% to 70-80%. So yes, if you find it, it proves it. But if you don't find it, your patient is progressing in front of you, and the only treatment available was when obinutuzumab or when Rituxan, you're going to switch class anyways. Or what's the point of checking it, because you're going to make a treatment decision anyways. Now I think the story is changing a bit in my mind, and I think this is similar to CML story, where, people who treat CML or Ph positive ALL, kinase domain mutation is very essential, because if you have a T315I mutation, you're going to use ponatinib and not dasatinib. It's very kind of somewhat structured. Or so the same argument, let's suppose I have a patient who is on frontline Acala or Zanu, and they are progressing now, and now I have an option of pirtobrutinib, and I have an option of obinutuzumab. Now, if I check a mutation on this patient, and let's say they have cysteine 481S, which is fine, but let's suppose patient also has L528W and they were on Zanu. Now I know that's a resistance mutation to pirtobrutinib. So, though I guess we don't really have this data, but I would be concerned about putting that patient on pirtobrutinib, thinking that they have a priori resistance mutation to pirtobrutinib, which likely will select over time. And that's a group of patient I may really think of switching strategy completely to obinutuzumab based therapy. On the flip side, if they only had cysteine 481S, then fair game, pirtobrutinib is perfectly fine. So I think to me, when you're immediately going from one BTK to another BTK, really the order will be colon BTK to non-colon BTK, immediately switching. I think given this non-cysteine 481S mutations and their resistance to pirtobrutinib, I would like to know the mutation status before I'm putting a patient on pirtobrutinib. Now, this is, I think, an evolving field, because these mutations are just we're learning about in the last 2-3 years. But at least in my practice, in the past, when I may sometimes say, oh, if you don't have a resistance mutation, it's fine, I'm going to do that anyways. Here I would, because pirto is an option, I will really make sure we check BTK resistance mutation, especially looking at non-cysteine 481S mutation, L528W for, with the acalabrutinib, and the other mutations as well. So that would be my thought about mutation kind of a testing in this context. But again, the options are still the same, pirtobrutinib and Ven-G. And again, I really, depending on the age of the patient, let's suppose for the sake of argument, patient is 78-year-old. As Bita said, they started 10 years ago on ibrutinib, now they're failing it. They may say, hey doc, I've been taking a pill every day for the last 10 years. I don't mind taking a pill again like pirtobrutinib. And that's, I think, is a fair approach, as long as they don't have a resistance mutation, non-cysteine 481S resistance mutation. On the flip side, younger patients, certainly a Ven-G would be, and where the Ven is good for 2 years, would be a very appropriate approach.
So Nitin, now what about the other scenario where you actually treated with a fixed duration venetoclax-based regimen and stopped, and then the patient progresses? Do you retreat? Do you switch? What are your thresholds, if any?
Yeah, so that's a challenging, and I think somewhat of a lack of data, lack of large prospective data, I should say. So I think one thing is clear, right? If you give Ven-G frontline, let's suppose the patient progresses 6-7 years down the line. I think people would argue that, okay, that's great. And I think retreatment with Ven-G is appropriate. And you may still get another 4, 5, 6 years out, which is fantastic. On the flip side, you give Ven-G and the patient progresses in 6 months later. Again, you can retreat with Ven-G, but if you're trying to treat it with Ven-G with a time-limited intent in mind, that's not going to help, because you're going to retreat and then the patient will progress again. Either you do a continuous Ven-G at that time, where continuous Ven long-term, which again is a strategy can be used, not really has been studied in the early phase of the trials, or you totally switch to a BTK inhibitor approach. Now, what is that right cutoff, right? Some people say, if I treat for 1 year with Ven-G, at least I should get 1 or 2 years of remission before I will retreat. I think to me, question also becomes, when you say retreat, are you talking about a time-limited retreatment or are you talking about a long-term retreatment? Because if a patient progresses even 3 years out, right? After 1 year of therapy, 3 years of remission, you're going to start them on Vengi again. But if I do Vengi for 1 or 2 years again, maybe I will get another 2-3 years again, but then the patient will still progress, right? So I'm not getting long-term. I mean, yes, I'm getting some mileage out of it. So to me, I think sometimes these retreatment questions, I'm not sometimes not sure what the intent of the retreatment is. If the retreatment is also meant to be fixed duration, that time limited, or something more prolonged. But I think the general thinking would be, yes, short duration of remission, you switch to a different class. Long duration of remission, we can potentially retreat and kind of, get some benefit out of it as well.
Bita, how do you think through it?
You just heard it's a data-free zone, or, they are trying to generate data, but the data is young. So the revenge is trying to answer that very question, in patients who have had first ven exposure and their PFS1, their, basically first progression-free survival from venetoclax exposure is 2+ years. It does make sense to re-challenge them with venetoclax. But my main question is, okay, what duration of venetoclax? Are we talking about 1 year? Are we talking about 2 years? So I think Matt Davids presented at the Lugano meeting with 25 patients, and, one patient progressed with re-challenging after being re-challenged with venetoclax. And the way I think that trial is designed is if your PFS1 is 2+ years, your re-challenge duration of therapy is 1 year, but if it's 1 to 2 years, you get 2 years of venetoclax. So I think the duration of venetoclax therapy is a huge question that needs to be sorted out. I am very comfortable if someone has had 5 years of progression-free survival to be challenged in the venetoclax. But then again, for what duration? That's something to be determined. I do think it makes sense, but I think it's an evolving field. We have more questions than answers. It is certainly an option with not utmost certainty. I'll put it there. But if someone, they had their first treatment at the age of 50, at 56, their disease is coming back, you give them 2 more years, and they go for a few years, and now they're basically in their 60s and their disease is coming back. But, if the diseases come back after first time limited exposure, the disease is destined to come back again. So how to sequence our treatment options again to clinically benefit these patients.
So we've had a discussion on pirtobrutinib, but the other modality of treatment that we haven't touched upon is CAR T cells. So Bita, where do you see CAR T cell utilization these days in CLL?
Yeah, so CAR T, got approved almost 2 years ago, March of 2024, for the double exposed/double refractory patient population. If you have a disease with inherently dysfunctional T cells, no matter how you manipulate those T cells, at the end of the day, they're going to be dysfunctional, as, the lysocell, lysocaptogen merlucell, or transcell CLL 004. The original, basically, results when it was published, the CR rate was 18%, the overall response rate was 47%, and the median progression-free survival was 1.5 years. But then they had a cohort that they added ibrutinib, a BTK inhibitor, and ibrutinib specifically has that ITK inhibition, which results in improved T helper 1 immunity of the T cells. So you get to collect more functional T cells. And that very cohort, when they compared it to the all-comers without ibrutinib, and again, it's very important to understand ibrutinib here is not providing disease control. These are patients who presumably have failed through covalent BTK inhibitors. It is to improve the function of T cells. Their overall response rate, check me on that, but I think the overall response rate went to 85% from 47%. The CR went from 18% to 45%, and the median progression-free survival went from 1.5 to, 30 months, which is 2.5 years. So truly introducing, I would say, any covalent BTK inhibitor, but even in ibrutinib, specifically with the ITK inhibition, did improve the functionality of T cells, and as a result, the outcomes of lysocells. Right now, if someone has truly a double refractory disease, and I'm more comfortable with double refractory than double exposed, because double exposed still has, I'm comfortable. I don't want to write off these really good treatment options until I absolutely have to. And some of the double exposed that I'm getting, referral to me intolerance to one covalent BTK inhibitor, and then they progressed on OV 4 years later. So this patient, you still can work with a lot before getting them to CAR T. But again, high risk, young patient, we know that those patients, a number of those patients who achieve CR stay in CR, at least with the young follow-up data that we have. So it is a niche treatment option for the right patient population, but it's also a little difficult with the growing armamentarium of treatment options. You have CAR T. Let's see how the bispecific story is going to pan out in CLL. BTK degraders are coming into play. So I think that question can be answered in an educated fashion once we compare these third-line treatment options in a head-to-head fashion.
And Nitin, anything to add on CAR T cells?
Yes, I think I would say that in the real-world setting, as Bita said, I think based on the data, the prospective data we had with ibrutinib, right? So ibrutinib plus CAR T. Well, as we discussed, we have as a field moved away from ibrutinib, though one could argue it could be used in the context of CAR T for ITK inhibition. There have been some other groups have reported that maybe it's not the ITK, it is the expression of BTK on myeloid-derived suppressor cells, which is really deriving the efficacy. So, which means that it should work as long as it inhibits BTK. So it should have acalabrutinib has the same effect as ibrutinib, at least in the preclinical models to CAR T cell therapy. But I think what we really need to do is generate prospective trials of second generation BTK inhibitors, and obviously pirtobrutinib will be the most obvious choice here. Some of these efforts have started or are starting right now. But there is also a real world consortium, a real world group where several institutions in the United States have come together to pool patients with CAR T cell therapy in the real world setting. And if you look at that data, which was at ASH last year, most of the patients in the real world setting are getting a BTK inhibitor. Whether it's ibrutinib, acala, zanu, pirto, a lot of them pirto. And actually combining them with CAR T, as was said with ibrutinib, CAR T plus BTK inhibitor, the responses are much better. It could be an effective debulking, especially in the case of pirto as well. I don't know whether that certainly helps. Or it could be just the synergy of the CAR T and a BTK inhibitor. And also, I think with the ibrutinib data, what the investigators showed, not just the efficacy with Bita highlighted, the rates of CRS and neurotoxicity, or what's called ICANS, were also decreased. So when it was continued throughout the course of treatment. So I think that's an important field, which I think we'll learn more as we and others are starting to do some work in this field of combining BTK with CAR T cell therapy. But I agree that I think the role for CAR T cell therapy is really for these double refractory kind of patients, younger patient, where I think CAR T will have an important role. The thing right now is that we have such effective therapies for our patients with CLL in the first line, second line therapy, that the pool of patients we have right now who really need CAR T cell therapy is a bit on the lower side, which is a good thing. But I think that therapy is available. And I think I would also say that unlike lymphoma and myeloma, where there's so many of these CD19 CAR Ts approved, I think we only one approved in CLL, right? So I think there may be a need, in my mind, to develop additional CAR T cell therapy approaches, not just CD19, a dual target, triple target, and I think eventually maybe those will come as well as the time goes on.
So winding up, Bita, what are the key takeaways from our discussion on relapsed refractory disease that you would like the community physician to take away?
So a lot of it depends on what they've received in the first line. Make sure to differentiate true progression from, I want to say a more gradual progression. And not everybody, as soon as who progresses, they need a new line of therapy. There are many shades of progression. But if someone is truly progressing on a covalent BTK inhibitor, I highly recommend checking the BTK inhibitor resistance mutation panel for all the reasons that you heard. And then the two FDA-approved options are venetoclax-based therapy with obinutuzumab versus pirtobrutinib. And again, patient preferences, comorbidities, logistics, all those factors play a role in choosing the next line of therapy.
Nitin?
Yeah, very similar thoughts. I think one thing I would say, and we see it sometimes in clinic, especially in the first line setting, or it could be second line setting as well. Patient is in a BTK inhibitor, they come to a clinic, they say, oh, patient progressed on BTK. But sometimes when you ask a bit more, and I always ask them, did you progress while you were actually taking the BTK inhibitor? Because sometimes what happens, they held it for AFib and they were holding it for 2 months, and now their disease starts progressing. So that's not a true progression on BTK. That's they were holding the drug. So if I get a history like that they were actually not taking it for that, a few weeks or month, 2 months, then that's a group of patients which will still be sensitive to BTK. That's just as, it progressed off therapy. Now, whether you go back to ibrutinib, if they were on ibrutinib or a second generation BTK, that's a different question. But I think that's a history which is important. And I have patients who are billed as or who are portrayed as BTK refractory, but that turns out they're actually just were off the BTK, and you can resume the BTK and they regain the response. It's kind of like, point of the history to kind of discuss, because BTK inhibitors stopped quite a bit in the community setting, I think, for infection and AFib and anticoagulation. So I think you feel mindful of the progression on BTK versus progression off BTK.
Well, thank you both for a terrific discussion. A lot has changed, and these are complicated decisions, and we really appreciate you sharing your expertise with us today. Thank you very much, both.
Thank you.
Thank you.